Thanks, Nicole. Good morning. Again, I'll echo the appreciation for spending some of your morning with us. And I'll echo Nicole's and Dr. Callahan's comments about the importance from our perspective of your attendance here. So I apologize for my colleague, Dr. Bustani, who could not join us this morning due to an emergency. But we decided some time ago that we were going to use this time without slides. So you're all used to seeing slides. And he said, you know, Noll, when you present with slides, I have yet to see you present in the time frame you're given to present. So my challenge this morning is to tell you our story of anticholinergics in the time frame that I've been given to present. And as Nicole mentioned, that we're going to try to do that in our time this morning with allowing a fair amount of time for feedback from you, a chance to ask questions about, you know, you told us this story, but you didn't give me this detail, or you didn't tell us how you did that, or who you worked with to do that. So I want to make sure that we have that opportunity to do that. And if I told you all the details that you all want to hear, we'd be here for the rest of the morning, right? Okay. So I am going to share with you some of the product that we have developed. And if time allows, my colleague Kunal Bodki, who's a UX designer who's designed an app for us recently, will be willing to share some of that with you as well. Some of that may have to be offline. But let me get into our story. So I'm going to start in 1970. So Nicole mentioned 17 years from discovery to delivery, right? I'm going to go back to 1970. 1970, or the 1970s, we learned, good morning, we learned that the cholinergic pathway was an important pathway for dementia. We learned that people with dementia had a deficiency of cholinergic neurotransmitters in your brain. So that at the time was a significant discovery. And we learned that, and that helped 20 years later, or if you want to tell a consistent story, 17 years later, roughly, pharma developed a class of treatment for dementia, which replaced this lost cholinergic pathway, right? So we had medications like that you would recognize as donepezil or Aricept, rasagiline, not rasagiline, that's a Parkinson's drug, sorry, rivastigmine. I recently gave a Parkinson's lecture at Purdue, so it's fresh in my mind. It's priming, it's cueing. That's a priming for something I'll talk about later. So we have the class of cholinesterase inhibitors that were used to quote unquote treat dementia, right? Raise your hand if you think these things actually treat dementia. Thank you. Appropriately, no hands are in the air. So this is a cholinergic theory that we've known for a long period of time. The treatment, by the time you get to dementia, that treatment mechanism is not a very efficient one. However, we believe that that pathway has an important role in the way we think, the way we find words, the way we store memory, the way we pull out memory. So not only is that pathway important, not only is it important in the progression of dementia, there are a lot of drugs that target that pathway. And we were particularly interested in some of our opportunity to pursue those relationships with some work that had been done here by some of our colleagues in departments of neurology, departments of psychiatry, through a longitudinal study of aging. So we used a database from a study called the Indianapolis-Abaddon study. And this is one of our first attempts to look at the relationship between drugs that block cholinergic neurotransmission and the outcome of dementia. So in 2010 was one of the first times that we actually saw some evidence from a relational study like this, okay? So we used this study, and it was conducted here what we used was data conducted here in Indianapolis and included at the time only African-American patients by nature of the intent of the study, actually. And what we did was we asked the question, do users of these anticholinergic drugs, are they more likely, less likely, or just as likely as non-users to progress to dementia? This is a group at baseline who are cognitively normal. And over the course of 6 years, we found that there was about a 50% increase in the chance of progressing to either dementia or a mild cognitive impairment. Either way, it was a worsening in cognition among those who were users of a particular subtype of of anticholinergic group. So I stepped a little bit ahead of myself, but before we could say, do these drugs increase the risk of dementia or mild cognitive impairment, or at least worsen cognition, we had to define what these drugs were. So there are a lot of easily recognizable drugs that you might recognize as anticholinergics. So those who have heard this story before would easily recognize drugs like diphenhydramine, which is Benadryl. Raise your hand if you took Benadryl last night or in the last week. Yeah, a few hands come up. I'm thinking about it. I worked in the yard this week and I've got some ivy that's starting to itch, but I'm not going to do it because I'm putting my brain over my body. So these are easily recognizable drugs like diphenhydramine. Some of the older antidepressant drugs like Elavil, amitriptyline, nortriptyline. Some of the bladder drugs, oxybutynin. So there are a lot of ways that you can get these drugs, either prescription and non-prescription. So we had to define these. We actually had to define them too, and we were interested in testing whether some of these stronger anticholinergics, easily recognizable anticholinergics, had the same effect as some of the mild anticholinergics. So what are the mild anticholinergics? Well, this is where it gets a little concerning. We wanted to know if somebody's using, there are certain drugs that a lot of people use. About half of the population, our older adult populations, are exposed at one point in time to a diuretic called furosemide or Lasix. Lasix actually blocks the cholinergic receptor to a small extent. It doesn't really result in clinically significant cholinergic side effects, but we wanted to test the theory that if people are taking a couple of these, do a couple drugs that might block the same cholinergic receptor, act like one drug that blocks pretty significantly or much stronger a cholinergic receptor. And so we defined these through the anticholinergic cognitive burden scale. And this paper this study with the Indianapolis Abaddon Project was our first chance to test that theory. And so we found that it's really the strong drugs like the Benadryls, like the oxybutynins, the bladder drugs, like the tricyclic antidepressants, like Elavil. It's really those drugs that's contributing the effect. And we've seen that repeatedly. But this is the first time that we were to find that the drugs like Benadryl, the drugs like oxybutynin, showed about almost a 50% increase in the risk of worsening cognitive impairment compared to non-users. We also had the ability in that particular study to test whether genes had an effect. So we found that ApoE4 carrier, which is a known gene to increase the risk of a progressive cognitive impairment, we found that that group had about the same risk, but the group who didn't have a gene, that weren't carriers, that risk went up to almost 80%. So it seems like the adverse cognitive effect of drug may be even more significant among people who don't have a genetic risk factor. So we found one study, we published it. We didn't just pat ourselves on the back and say, great, job done, right? So we kept finding other papers and other populations to study this in. We worked with some colleagues outside of Indiana University. We worked with people outside of the country. And we saw over time a number of publications from around the country and around the world who saw a modest increase in the risk of cognitive impairment among users of anticholinergic drugs. We also found that this relationship seems to be dose dependent up to a degree, but we're seeing a consistent increase in the risk of 30%, 50%, depending on how you define the outcome and the exposure. So there's a modest effect. Now, if we were to take all these drugs away from people who are using them or prevent their use, we're not going to solve dementia, right? But let's think about what are the risk factors for dementia. Age, can't change that. Gender, can't change that. Health, nutrition, exercise, you can change those. But that's pretty hard. Can you change a drug? Yeah, you can change a drug. So we think that this is particularly important. Now, you might also say in the back of your mind, Noll, I know that there are a lot of drugs that affect cognition. Benzodiazepines might affect cognition. Anti-epileptic drugs might affect cognition. And you're right, they can affect cognition in the short term. But what's interesting about the cholinergic pathway and the way that some of these drugs particularly work is that they may also be increasing the pathology that we think is causing dementia. So there's a particular mechanism, and we've learned this more recently, between roughly 2005 and 2013, is when we started to see some mouse models supporting our focus on anticholinergics specifically. So this mouse model says that these drugs might be hitting receptors in your brain that are contributing to more pathology. We learned that from a Parkinson's population as well. So if you're a user of a benzodiazepine like lorazepam, or an antiepileptic like gabapentin, a lot of users of gabapentin out there, we think that if you take those drugs away, then in due time, your brain should recover to baseline. Whereas the cholinergic drugs, we're not sure. If we take those drugs away, of course, there's an acute effect on cognition. We think that acute effect should resolve. But does that change your risk for a later occurring disease, progressive, irreversible dementia? We don't know yet. So, as I mentioned, we've seen in a number of particular studies a consistent effect, a consistent relationship between anticholinergic use and worsening cognitive outcome, one that we can't ignore. So the next question is, what happens when we take these drugs away? What evidence do we have when we take these drugs away? And as I start to tell that part of my story, and that's the last part of my story, I promise, and then I'm going to stop and I want to take some questions and have some dialogue with you all. I'm going to tell you two stories here. One story is a patient from the Healthy Aging Brain Center who showed up after a 2-year decline in cognition that was recognizable to them, to this patient and mostly her family and her caregiver, who was her husband. She showed up, progressive decline. She was wheeled she came in a wheelchair into the clinic. She had a fairly flat affect. She could hardly put together a sentence. And if you asked her a question, she would answer with whatever was in her mind at the time, not responding to your particular question, just talking in whatever she wanted to talk about. And again, it wasn't hardly recognizable. She mumbled, she lost her train of thought, and she was depressed. So this was a patient of Dr. Bustani's. He saw her. They could not even complete an initial cognitive testing. Got an assessment of what her medications looked like. He called me. You can imagine where this story is going. He said, here's our chance to learn what happens when we take these types of drugs away from people. She had 28 drugs. Pick your poison. She had 4 strong anticholinergic drugs. She was on 2 benzodiazepines. She was on 1 antiepileptic. As you think about anticholinergic rating scores, if you apply an anticholinergic cognitive burden score, which rates drugs 1, 2, and 3, her score is 15. We think 3 is roughly where it gets to be bad. So I met with them at their follow-up visit, and we talked about what her priorities were. And she was there because she was concerned about her brain. So that makes this a little bit easier. She was already motivated to improve her brain health, and see what we could do to potentially help her. So we talked about an intensive plan that was going to take at least 6 months, most likely 12 months, to start to take some of these drugs away. She agreed. We started real slow, but we focused on the anticholinergic drugs to take those away first. And this represents mostly clinical opinion, expert opinion. When Malaz called me, he said, great, here's our chance to take these drugs away. I said, great, now what do we do? How do we do this? So I'm a pharmacist. I don't know how to do this. I know what Lexi says. Nobody studied deprescribing protocols for anticholinergics. So I'd like to say, well, I'll just pull this out of my hat. Well, I didn't have it. So I said, I learned real fast. What does we learned about this term in this process too, about deprescribing. What does this term mean? What is it? We just want to take drugs away. And geriatrics has said, we've been taking drugs away from people for a long time. Well, how do I take 4 anticholinergics away from this particular lady? How do I prioritize those? What if I just stop them today? What will happen? I got a pretty good sense, at least the clinical side of me says, don't just take them away. We should do one at a time. We should taper some of them slowly. Some of them we think we can take away. So we set this plan, and we understood a little bit about what deprescribing means, and so we set this plan, and we talked to her. We took about 2 months. We took 2 drugs away over the first 2 months. It was going okay. She was starting to give me some signs of, this is fine. I'm feeling a little bit better. I'm starting to move a little bit better. I should also say that she also received the package of the Healthy Aging Brain interventions for brain health, which include cognitive training, which include physical exercise, which include controlling all of her other disease states as well as depression. So she's receiving all of those benefits. After about 2 months, she came back to us. We had reduced some of her drugs, and she was delirious. And I said, crap, we did this to her. We took away drug and we made her worse. And then I learned, no, we didn't. She went to see a dentist, had a tooth extracted, got a prescription for OxyContin. We didn't do this. Well, we kind of did do this, okay? When she first came in, many of you would recognize an MMSE, right? A mini mental state exam, common measure used, global measure used for assessing global cognitive function. We all should be about 30 in here. The highest score, it means normal global cognitive function. She was at 16, which is about a moderate dementia range. When she came back after 2 months, she was at 10. She had gotten worse, and she was inattentive, and she was using OxyContin 3 times a day, because that's what the prescription said. And if anybody's scared of pain, it's this woman. That's why she got 28 drugs to begin with, right? So Malaz actually said, whatever your schedule was, we're speeding it up, we're stopping everything. And I said, that makes me nervous, Malaz. I don't know if I can do that. So we did fast forward our plan. We got her off of, we had a plan to control pain without OxyContin. She was about 2 weeks out of this procedure anyways, and pain should not have been much of an issue. And if it was, something was wrong. So we didn't want to mask an appropriate pain. So we took her off the OxyContin, gave her a routine schedule of non-narcotic pain medication, and continued with our plan. Well, about 2 months later, we got her off a few more drugs. She came back. She walked into clinic. She was smiling. She could talk in sentences, and she felt a lot better subjectively. Her quality of life was much better. Her MMSE at that point was 29. Was 27. We got it up to 29. Over the course of about 9 months, it took to get her off of 5 drugs, reduce her benzodiazepines by 50%. We didn't get them all the way off. She still has not gotten them all. She would still have not completely taken away her benzodiazepines. But on her repeated cognitive testing a year later, she scored within normal limits for an age, gender, and education matched control. So we helped her. Did we prevent her from getting dementia? I don't know. But we saw some evidence to help her. And that was an exciting story for us. We still celebrate her as a success story for deprescribing. So let me go back to what our next steps entail. Our next steps entail, we want to do this more universally. We want to take this benefit and see if we can expand that to the population through deprescribing trials. We're going to find people who are using these medications and take them off. But how do we do that? As we were thinking about how do we do that, we learned that, we're actually probably some of the more experienced deprescribing interventionists than what this country has to offer. We've actually been deprescribing in clinical trials for 13 years. We started deprescribing in 2005 in Malaz's eChamp trial. And we found in that trial, we're not good at deprescribing. So we found a population, a hospitalized older adult population with cognitive impairment, either delirium or dementia. And we tried to prevent their exposure to anticholinergic medications. We tried to do that through a computerized alert. So at the point of order entry, when a physician, nurse practitioner, or PA is entering an order for an anticholinergic, we said, hey, this probably isn't a good idea. How about you, actually in this particular study, we just said, pick something else. How effective were they? Not at all. We didn't change any new orders. We didn't change any renewed orders. We did slightly have an uptick in discontinuation orders, but we didn't change new orders. We didn't change the behavior. The feedback we got from physicians was, I don't want a computer to tell me how to prescribe. Makes sense, right? We said, well, how do we resolve this? What do you suggest? They said, well, maybe give me a clinician. When that order pops up, give me a resource, somebody else that I can talk to make that decision. I said, okay. So a few years later, we introduced a delirium treatment study, another randomized controlled trials in ICUs. And we said, we're gonna provide what we think is pharmacologically the best care of delirium in the ICU. And that includes deprescribing 2 classes of drug. One is anticholinergic and another is benzodiazepine. We said, well, we're going to do the same thing. We're going to provide these same electronic alerts as warnings. But if that doesn't work, and we suspect it won't, we're going to have a pharmacist call them immediately after. We're going to have that pharmacist check orders twice a day. And that pharmacist is going to call, page, email, text, do whatever they have to do to communicate with the team to say, this is not a good idea. You should do this differently. We came a little bit better prepared this time. We said, here's a list of alternatives. We gave them a list of alternatives through the electronic alerts to choose on their own. How successful were they? Well, we just found out a little while ago we weren't particularly successful there either. But we've been deprescribing unsuccessfully. We've learned some lessons on how not to do it. So now we know not to rely solely on EPIC alerts or EMR alerts. So why did we fail? We failed because the decision to deprescribe is perhaps harder than the decision to prescribe. It takes a lot of, what we were trying to intervene on was a time point when the decisions about what medicines to use had already been made, and we were trying to change that decision after the fact. So now we're thinking about maybe we need to intervene on that decision before. Maybe we need to target a physician well before they're making a decision, prime them, if you will, about thinking about what drugs they should not be using. We also learned, and we had with some support from AHRQ a few years ago, Dr. Callahan as a principal investigator, we had an opportunity and some support to learn more about how we could be successful in deprescribing anticholinergics. Anybody know that? I'm getting to, can you log in real quick? Thank you. So we had an opportunity to learn from all the stakeholders about deprescribing. And one of the most important lessons was what we learned from patients and their caregivers. Patients and their caregivers don't know about anticholinergic drugs. What is an anticholinergic drug? Many of them can't pronounce it. That's okay. They don't need to. They don't know what the risks are. Therefore, they don't know how to prioritize their risks. And so we learned that through this work funded by AHRQ, and that taught us, and about the same time, we understood from a colleague of ours in Canada who published a study that said, if you tell patients, if you provide education, and you help them through this decision of whether to use drug or not use drug for a particular symptom, many of them will stop on their own. So we thought, wow, patients are a really nice target, a really nice opportunity for us to give information. If we consider patients consumers, and we give them information, and then we direct them towards their physician or pharmacist to help make these decisions, then we might have more success than if we just throw a bunch of alerts at a physician. So through this brain safety learning laboratory funded by AHRQ, we have developed patient-facing interventions. But we can't do that exclusively. I'm going to ask you to pull this up. You might have to dig into your email. I apologize. Well, I don't see it though. Oh, Wrong one. Perfect. So we developed a host of patient-facing materials that help prime patients. And our goal is not to help patients make their own medical decisions, but to help them improve their awareness of what some of the risks of their medicines are. At the same time, we realize there are a lot of stakeholders involved in deprescribing. Physicians, healthcare leadership have a role. Pharmacies have a role. Pharmacists have a role. Thanks, I'll get it from here. I was expecting Mozilla. So we have to, if we want to be successful at deprescribing, we learn from our lessons of how not to do it. And we learn also that there are a number of pieces of the pie that we have to address. So one of the things that we're using are these nudge techniques. And these nudge techniques says, in order to get people to have a conversation and make a decision and change their behavior, one of the things that we can do is prime them. Tell them, make the patients aware, make the physicians aware about their risks of these medicines, and unfortunately, let them know that a lot of these medicines have alternatives. These alternatives are most often equally effective, and we believe them to be safer for their brain. And I'm going to show you next one of the videos that we've created to help spread this message. And again, these are patient-facing. And then I'm going to close and open the floor for some discussion. So I'm going to show parts of one more. And again, our intent with this particular product is to make it available in waiting rooms, to direct attention to it before patient visits happen, before they are in an interaction with their physician, in the hopes that it gives them something to talk about. This is a second video, and you might have mentioned, or I should mention that you might have recognized some of the voices in this video. Most of this are IUCAR, either investigators, staff, with a few other sprinkling of some from some of our colleagues in the School of Informatics who helped put these videos together. But I'll show just one more, and then I'll open the floor for some questions and dialogue. So as I mentioned, this is part of a suite of interventions that we intend to introduce. We're partnering with the Eskenazi organization, and we hope that later this summer we'll have a number of some patient-facing interventions, such as the videos that we'll make available. We have an app that my colleague Kunal Bodki here has helped design, and we'll make that available. We'll make some patient education materials available. Dr. Callahan has also been working with Eskenazi leadership for some time to get them on board with the mission, the initiative of reducing anticholinergics across the entire system. And they're developing an evaluation plan for what happens, how can we track what's going to happen when we turn on all of these host of interventions. Is it going to be a good thing? Are we going to make people go to the emergency room more often? Are we going to make them leave Eskenazi? We don't know. But we're trying to develop measures so we can track what the good outcomes might be and what the bad outcomes might be. So as I mentioned, our interventions here in this direction are in deprescribing, and we want to understand if taking potentially bad drug away from people is indeed a good thing, and we'll wear our scientific hat at that. So thank you for your attention. I'm going to end there, and we've got, I think our schedule says we've got about 15 minutes available for some interaction, so I'm happy to take your questions. And as Nicole primed you a little bit before, I'm happy to take your thoughts on where your particular area of interest might be in this field, how you might contribute to it, where your interests are, and how it could benefit this work. By way of a brief explanation, these microphones on the table, if you press the red button, Nicole will demonstrate.
Yep. So just press the red button and talk into it, and then when you're done, press it again.
That way we can all hear your question. If not, I can come around with a microphone.
Wireless, you can pass them around, so everybody at your table can contribute.
Okay. Let's go here and then back to the back table. Go ahead.
I'd like to know. Oh, hi. Can you hear me? Is it working? Okay. I'm Janet Pannock, and I'm a PhD candidate at the Communication Studies in Health Communication. And I love the animation. First of all, I thought that was very cool. It reminds me a lot of the Eric Carle children's books, you know, with the kind of the cutouts and the collage. So it's a unique kind of animation. I'm working on animation and some projects to introduce patient activation to high school students in health and wellness classes and encourage active engagement from patients, young people before they become patients. So I'm curious about how your audience responds to the animation aspect, because I talked a lot with young people about would they prefer animation versus real people. So I would imagine you've tested this, maybe had focus groups and things like that. What have the responses been to the animation itself?
Good question. And all I can say thus far is we haven't gotten to we haven't tested yet in end users. We've gotten some feedback from healthcare teams, healthcare practitioners. And our intent to use video was intentional. And we felt like we learn and we send messages through story. And at the time that we were developing this and getting closer to this part of the intervention, we felt we were also reading about how we spread messages to the lay public and how we increase awareness, increase education of the lay public. And we felt like through video, through television, through something that was shareable through even social media was a way that we could spread the message. So we intentionally wanted to go after this. The minimal feedback that we've gotten from potential users, as I mentioned, was the healthcare practitioners, and they felt like the message was appropriate. Felt like it would be well received. Outside of that, we haven't yet tested in end user. Kunal has done some work with our app-based education and awareness program, and found that, as we expected, that using an app and interacting with an app from a perspective of raising awareness we think is going to be successful. But with the video, we don't know yet. And like I said, our goal is simply to get them to take the next step of seeking information or having a conversation. So if you or anybody else have experience with what an end user's feedback might be from similar products, I'd be happy to hear that too. Yeah.
Dr. Campbell, thank you for this information. I'm Melanie Perry, and I'm the Director of Memory Care Support Services with American Senior Communities. And so immediately when you're talking about getting to the public with this information rather than trying to use the avenue of a physician, I immediately thought of our approximately 70 communities across the state where we do offer family education and support groups, and thinking how much we would love to, to share this video with our family members that come to these groups. And so if there's any way we could have access to these, as you were saying, that would be awesome and be a great way for us to reach quite a few Hoosiers across the state in a very simple way. So if we could help share this video, we would love that opportunity to do that.
Awesome, thank you. I know that extended care facilities, I know that assisted living facilities are particularly on board with the anticholinergic reduction initiatives, and nationwide doing a fair amount of activity themselves. And we're happy to share these. I think we're interested in learning, as much as we can from them and getting feedback. So thank you.
Thank you. And then I did have one question, if I might, regarding the study itself. So I know that you said, when people stop the use of the anticholinergics, that there is still uncertainty about if that does stave off potential symptoms later in life, or to what extent that there may be a connection between stopping and preventing dementia later in life. Is there any sense yet from your studies about where age of use comes in? So I'm just thinking of my own personal life, as a kid, high school, college, going through lots of allergies, using diphenhydramine fairly frequently and fairly prolifically. And then as I've gotten older, intrinsically it seemed correct not to use those synthetic types of interventions, but rather search out more holistic interventions, and have not used any since. So just wondering, have you gotten a sense of age of utilization of the anticholinergics and potential risk later in life for dementia? Just asking for a friend, really.
Yeah. It's a great question, and I don't know if I have presented on this topic and not gotten this question. And unfortunately, the news that I can report is probably not in your favor. And this comes from some of our work locally and some of our work that we share with partners in the UK. And about 2 weeks ago, we published a paper in the British Medical Journal, and it was one of the largest and one of the longest longitudinal studies. Now, again, the nature of these types of studies are not to determine cause. So I need to say that, but these studies, like most of our work, determines the relationship between use of the drug and an outcome. And so this particular study went back and compared, in a case-controlled design, compared people with dementia and looked back at their prescription exposure for 20 years. Now, the people with dementia who were diagnosed with dementia were in their 80s. So that 20-year period is early 60s. So I'll pay you the compliment and tell you, you're not there by any means yet. We have local, and so the moral of that story was that risk was consistent, whether your exposure to the drug was in the 4 to 10 years, 10 to 15 years, or even 15 to 20 years before that diagnosis. So that relationship really held as early as the early 60s. We've also performed work down as low as the age of 55 by enrolling a population at 65 and over, and with a mean age of about 70. And seen a consistent effect and consistent relationship between that down to the age of 55. Beyond that, I don't have any data. But so the other piece of that puzzle is with some of the work that I'm doing with my career award from the NIA right now. And we're trying to draw this link of is there a time-dependent exposure that's really important? So we've seen from some papers that people, when you get to the point of dementia, having a diagnosis of dementia with recognizable symptoms, where we feel confident about I shouldn't say feel confident about the diagnosis, but a diagnosis of dementia is made, that perhaps then the cholinergic pathway in your brain isn't modifiable anymore. And that could explain why the procholinergic drugs, the cholinesterase inhibitors like donepezil, Aricept, aren't particularly effective, because we're trying to manipulate a pathway that maybe is damaged. And so the epi work from anticholinergic studies suggests that the later we get into progressive cognitive impairment, the less important anticholinergic drugs become. And so we've seen that in a couple papers, and I just recently published as well a paper that says the transition from normal cognition to early stages of cognitive decline, or also known as mild cognitive impairment, that these drugs are increasing that shift. And we've got analyses also that says they're also preventing you from getting better. So MCI is kind of is seen as a transitional stage to dementia, from normal to mild cognitive impairment to dementia is what we think about it. And some people go back and forth between MCI and normal cognition. That may not be a true Alzheimer's type of pathology, but we're seeing the anticholinergics do increase the transition from normal cognition into that early phase. And so perhaps it might be that the people that we really need to pay attention about are those of us as we age. And I can't give you anything more specific than that, but that's kind of where our level of thinking is. And that's why we think going to primary care populations, going to ambulatory care populations who aren't yet experiencing symptoms of cognitive impairment, those are the people maybe who are going to benefit the most. And those become our targets. Good question. Yes.
I have two questions. I'm Susan Hinshaw. I'm with Joy's House. Two questions. First is, what's the focus on medical schools and teaching physicians how to better treat their patients so that we don't have to deprescribe, they're just being prescribed the correct medicines to begin with, even beginning with pediatrics with Benadryl. Second question is, you mentioned about the APOE4 gene and how there didn't seem to be in the one study as much of a difference for people who already had that. So what's done with people who already have that one or two genes? How are they being studied differently?
Good question. To quickly respond to your second question, I'm not approaching the people with a genetic risk factor versus without differently for a couple reasons. One is it's not a routinely available clinical measure. I can't go into the charts and find if somebody has an APOE4 yet. Perhaps one day we will, and perhaps we'll learn if we should focus deprescribing interventions on those without it. Which is 2/3 of the population, right? And it could be that the APOE4, as much as it's going to influence cognitive impairment, is not as much dependent on drug exposure then. So I'm not differentiating interventions or outcomes based on that at this point in time. Your first question is a good one. And at this point, the only training that we are providing to medical students, and I won't limit to medical students, pharmacy students, social work students, therapy students, is what we encounter when we see them on a one-to-one scale. And it's not integrated right now, to my knowledge, in educational systems. There has been a recent call for materials for this to be integrated, for deprescribing in general to be integrated into our curriculum. But again, there's a lot that we're starting to learn. We're just beginning to uncover about deprescribing. And there's a lot of debate about deprescribing. Is it evidence-based? Is it not evidence-based? And the truth is, if we want to be evidence-based practitioners, there's not a lot of evidence for use of many of these anticholinergic drugs beyond what they've been studied, right? So let's take, for example, the case of bladder antispasmodics. Drugs for urinary incontinence, oxybutynin and tolterodine are probably our worst offenders. Some of the newer agents, we could argue about whether they are as bad for your brain or not. But most of those drugs have been studied for 12 weeks to get an FDA indication. So there's not much evidence beyond 12 weeks. So if we're practicing evidence-based medicine for those drugs and other drugs, maybe antidepressants beyond 2 years, right? We should be stopping these drugs at the end of when they've been studied. That's evidence-based medicine. And perhaps if we do that, we reduce exposure and we reduce adverse events. You know, adverse events are not restricted to your brain. I'm talking about brain-related adverse events. But there are a lot of other adverse events that may occur because of chronic exposure to drug. And so there's interest, morning, Maria. There's a significant amount of interest in pros and cons of deprescribing around the country. And so much so, in fact, that just yesterday, National Institute on Aging released a network grant opportunity to develop a deprescribing network within the country to bring together and prioritize research for deprescribing. And so that's pretty exciting to us too. What do I think about the politics that would play in? That is a complex adaptive system. And who better to address a complex adaptive system than IUCAR? Thank you all for your attention. Thank you for your questions. I unfortunately have to leave. I'll be around for about 15 minutes, but I unfortunately have to leave for a department retreat today. But I appreciate I really appreciate your attendance, the opportunity to speak with you this morning, and appreciate your attention. Thank you.
Thank you, Noll.